Hello everyone. Today we're going to be looking at some tips and tricks on doing a hot swap on IV infusions from the hospital's IV pump to your IV pump. We're just also going to go through some general good rules of thumbs when transferring patients on various types of IV drips. So if you're not very familiar with IV pumps, there are two types of tubing. If you'll see this one here, it looks a little different than this one that's in the pump currently. What is the difference? Well, this one does have a spike or a drip chamber. Instead, it just has a male and female lure lock, kind of like this. So what do you think this might be used for? Well, it's if you're transferring a patient from the hospital and you want to switch over from their IV pump to your IV pump, you can theoretically just attach this half set directly onto the end of their line, flush it, prime it, and then put your cassette into your pump and transfer settings from their pump to your pump and do it this way. The other way to do it is to completely respike the bag with the cassette and the full set that works for your pump, right? And the full set would be pretty much the same thing as this, with the exception of having a drip chamber and a spike. So in many cases, it's okay to simply attach this half set onto the end of the hospital's line or set, and just transfer the medication over that way. The drawbacks to that are, well, one, when we're transferring over, we have to actually disconnect the medication that the patient's receiving, then add ours on, prime it, reconnect it to the IV catheter, the extension set, and then we can continue the pump. So it takes some time. What if the patient's on a medication that's critical? Let's say it's a patient that is in severe shock, that has maybe multiple vasopressors going, and we want to limit the interruption in that medication that's being infused. It could also be a patient that's on a sedative, and that sedative is maintaining an adequate RAS, and you don't want to stop that either. Maybe they're on something like propofol, and the half-life of propofol is very short, and if I stop this, for more than a few minutes, this patient could wake up, especially if we're exposing them to any kind of stimulus. All right, so let's imagine we're doing an interfacility transfer. Let's say the patient's on, nearly their max dose of norepi, and their hemodynamics are dependent on vasopressor support. So imagine this is the hospital's IV pump on the bottom, and this is our IV pump. So what we would do is we would say, okay, the patient looks like they're on 5 micrograms per kilogram per minute of norepinephrine. So what am I going to do? Well, I'm going to go ahead and set my pump up. So when I turn it on, I would get to this screen. I can hit New Infusion, and I can go ahead and hit MN for norepi, find, and I see norepi here. And then I would mimic the hospital's concentration. So we're going to do 4 milligrams and 250, which is pretty common. Enter the patient's weight, and I can look on the hospital's pump, see what weight they put in, and I could enter their weight. So let's just do like 75 kilograms. Okay. Rate, I can see whatever rate I went to, mics per cube per minute. once I hit the dose rate, I do have to enter the volume to be infused. So let's say, you know, there's 200 left, 200 mLs. Okay, and then I can hit OK again. And this pump's ready. I have to hit next. I confirm all of this, the weight, the concentration, the volume, and then I'm ready to hit start. So what I'm going to do now is I'm going to do what's called a hot swab. So basically, I would need my my full set, some medical tape, and all I have to do is I'm going to go ahead, take the drip chamber on the hospital's pump, go ahead and fill it completely to the top. I'm going to get a few pieces of tape ready, or I could get the tape ready first. I'm going to get this tape ready, or just one sufficiently long piece of tape. I'm going to take their IV bag. I'm going to remove the spike, and then I'm going to set the bag to the side, making sure I don't spill any contents. And I'm just going to tape this this drip chamber right here, so you can see that the medication will continue to run even with this out of the bag. So then I'm going to take my drip set, my full set. I'm going to spike the hospital's bag of Norampi. I'm going to make sure all of my clamps are off. And I'm going to check my cassette and make sure that it's not clamped. And then I'm going to open that up, and I'm going to push all of this air out of the bag. I'm going to make sure that I prime this line. Alright, this line is primed, so I'm going to go ahead and clamp that off. I'm going to hang it. I'm going to put the cassette in my IV pump, like so. Close the door. What I can do is I have this in hand ready. I stop the hospital's IV pump, and then I disconnect from the patient's IV catheter or extension set, connect mine, and hit start. And then we have had very minimal interruptions in this medication. Alright, another drawback to using an extension set is you can see that this tubing is very long, and basically you're just going to have a mess because you're going to have, you know, something like, you know, 15-20 feet of IV tube. I don't know if it's that long, but it feels like it. Something else you need to be something else that is good for EMS to be cognizant of when transferring a patient on IV infusions is to make sure, especially in certain medications, that the patient gets all of the drug. This is especially true for thrombolytics and for antibiotics. There's a lot of nursing literature out there showing that this is not the case, especially when it comes to antibiotics. What happens? Well, as the medication's infusing, once the bag empties, the medication will continue to go down the IV tubing until you get some air in the cassette, and then the IV pump will sense that and stop the infusion. Then if you hear that, you think that the medication is done, so what do? You know, you pop this off, you disconnect it from the patient, you throw it away. A lot of volume can remain from here down to the patient. Quite a bit of volume can remain from the bottom of this cassette down to the patient. The patient needs to get the full dose, not just a partial dose. And the bags of antibiotics are relatively small depending on the antibiotic. It could be, I don't know, something like 100 or 50 mLs. And if your IV set can, you know, hold about 20-30 mLs roughly from here down, then that could be nearly half of the medication that the patient's getting. So how do we fix this? Well, there's a few different ways. It's very common in hospital to piggyback. So let's say that this is the primary infusion. It could just be a bag of fluid. that's hanging. So the patient is getting this infusion, and if the physician orders some antibiotics, what the nurses will do is they'll come in and they'll prime the antibiotic. So this is considered a secondary infusion. They'll prime the antibiotic. And let me make sure that this is all open. Prime the antibiotic, flush the line. So if a physician orders some type of secondary infusion, then if the physician orders an antibiotic, a lot of times the nurses will come in, they'll spike an entirely new bag with a very specific drip set that's shorter than the rest, so that the secondary infusion can be attached to the primary at the luer lock port above the IV pump. Then, once they prime their bag, they'll connect it on this luer lock, and they usually have this big long hook. I'm sure you've seen it in the hospitals. It's basically a long piece of plastic with two hooks on the end. So they will lower the primary infusion with this hook, and they will hang the secondary infusion something like 8 to 10 inches above the first. This allows gravity to make sure that the secondary infusion is preferentially being powered through the IV pump. The good thing about this is, once this infusion is done, then the primary infusion can take over. So if you are transferring a patient who has an antibiotic as their primary infusion, meaning it's not the secondary, hanging up like this, if the antibiotic, let's say this is the antibiotic and it's the primary infusion, and it's going directly into the IV pump, when it gets low, once you see it getting low, you can pause the pump, take this spike out from the antibiotic, and of course I want to get the air out, but if it's actually a new bag of saline, it's not going to matter, because you can hang it up like this and then spike it directly in from the bottom, but I can't do that with this, so I'm trying to simulate. But anyway, you would just re-spike it with a fresh bag of fluid to make sure that all of that medication gets flushed from the line. Okay? Something else that you might not be entirely aware of or cognizant of is IV catheter dead space. And we're not just talking about dead space in the IV catheter itself, because honestly there's not a whole lot of dead space in an IV catheter that would make a big difference in most cases. But if you add the dead space that's in the IV catheter and the dead space that's in your extension set, it's a big deal. It's mostly a concern if you've had IV fluid going and then you start a new infusion. It could take a long time for that medication to get from here, where you actually screw on the drop set, all the way to the patient. If you're given a medication that is very concentrated and that has a very low drip rate, it could take a long time. In some cases, it could almost take the duration of your transport, especially if you're given a highly concentrated medication at the lower end of the range. This is true for norepi. Imagine if the hospital uses a very concentrated norepi, which honestly should not be given through an IV. It should be something like 4 milligrams in 250. It's also true of something like nitroglycerin. If they start off low, and hospitals, of course, commonly start nitro off at around 5 mics per minute. It's going to take a while, and you could be halfway through transport before that medication even gets to the patient. So how do we remedy this situation? In most cases, if you're transferring a patient that's already on an infusion that you just plan on swapping over to your IV pump, it's not going to be a big deal because the extension set that they have on has already been primed, presumably. It does become a big deal if you initiate an infusion in the field, or if the infusion is initiated right before you get to the hospital to pick up that patient. So this becomes a big deal. So let's imagine you're at the hospital, you're getting ready to transfer a patient over, and as soon as you get there, let's imagine that let's imagine that they had just intubated the patient and they're getting ready to put them on a propofol drip. You have a few options for this. So if they're on a propofol drip, maybe the patient is going to start waking up because it's going to take a few minutes for that medication to get to that patient. Well, one, you could increase the rate on the infusion, just gently titrate it up within protocol or with consult of the ER physician. That is one option. So in general, I don't think, if you are mostly just transporting patients that have an IV catheter and not a central line, in most cases dead space is not going to be a big issue, but it is something that you need to be cognizant of. And if you show up to do an interfacility transfer and they had just switched the patient to a sedative or a vasopressor or something of the like, and you're not seeing the physiological effects that you would expect to see when that medication is being given, you should probably consult with the sending physician or the RN and ask if they had primed the extension set, and if they had not, ask to increase the rate of the infusion briefly until you start seeing the physiological effect that you expect, and then titrate back down.
When you're transferring medications, the patient could be on multiple different vasopressors. They could be on, a sedative, an analgesic. So that all gets very messy. So what we have to decide is, what do we need to convey the patient on to the receiving facility? What do we not need to convey the patient on? If the patient's on some electrolytes, you might want to consult with the sending physician, help and coordinate with them to create a care plan for how to treat this patient during transport. Just say, hey doc, it's logistically difficult for us to transport this patient with 20 different medications. We like to say that's what we do as paramedics. We're able to handle and juggle a lot of things at once. But what it really does is it increases our chances of making a mistake during transport. And we can minimize that risk of titrating the wrong medication, having something go wrong and not knowing what causes it. We can minimize that as much as possible. So if the patient is on, a paralytic, do they need this paralytic during transport? At our department, it is not preferred to transfer the patient on a paralytic. We use analgesia and sedation. If the patient is on a sedative and an analgesic, are they a candidate for a ketamine drip? We could decrease that from 2 IV pumps or 2 channels down to 1. This is something that you can just use, good clinical intuition in coordination with the sending facility on. Something I do want to talk to you briefly about is cheating when you're transferring the patient from the hospital pump to our pump. It is really easy and convenient to hit New Infusion, choose General, and hitting mLs, weight-based infusion, no, mLs per minute. And then setting the rate, whatever the hospital's rate is going at, let's say it's 50. Well, we can't do that per minute because that is too high for this pump. So let's say 10. Okay, and then the volume to be infused, let's say there is, see if I can get this to focus. Let's say that there's, 100 mLs left. And then all we would have to do is hit OK, 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 and start. Now, what is wrong with this? Now, what is wrong with just copying the mLs per hour or the mLs per minute? Well, we're not giving a concentration, right? What if we need to titrate that? A lot of the medications that we administer aren't in actually mLs per minute. They might be in milligrams per minute, units per hour, units per kilogram per hour, micrograms per kilogram per minute, right? Those are units of measurement. That's how we communicate how much medication a patient is getting when they're on an IV infusion. It's not via mLs per hour. There are very few medications that are given like that. You give fluids mLs per hour, mLs per minute. Some antibiotics maybe are, mLs per hour, mLs per minute. Not 100% sure. The moral of the story is, let's say you're transporting this patient on a norepi drip. They have the patient on, let's say, 0.2 micrograms per kilogram per minute. And it's going at, I don't know what that would be, but it's going at like 10 mLs a minute. That might be a little high. Sounds a little high. It's going at like 5 mLs per minute. All right. Why not just say we're given 5 mLs per minute of norepi? Well, the problem is, what if the patient's blood pressure starts dropping and you need to increase that? And yeah, it's going to be okay for you to increase that if you need to, if you're not at your max dose. But you're not going to know if you're at your max dose or not, especially if you're given norepi in mics per kg per minute. It's going to be hard to calculate that on the fly. It's going to be hard to say, well, the patient is, the concentration is this, it's 16 mics per ml, so if they're at 5 mLs per minute now, that's, so I need to increase it to 6 mLs per minute. You are increasing your risk of causing a medication or administration error, especially if you need to adjust the medication quickly. And even if you're transferring a medication that is not programmed into your IV pump, you can still go in and manually input this. Let me demonstrate. So all you have to do is hit New Infusion, choose General, hit OK, dose calculation. So let's say that we're doing a norepi drip and it is 4 milligrams and 250 mLs. So that's pretty easy. 4 milligrams, okay. The volume is 250, okay. 4 milligrams in 250, so it gives you 0.01 milligrams per ml. 4 in 250, okay. Weight-based infusion, yes. Patient's weight, however, whatever their weight is in kilos, 70 kilos, okay. And what is your units? Well, they're mics per kg per minute. I need to turn this other pump off.
It's mics per kg per minute. So we hit the rate. So we need to look at the hospital's pump or communicate with the nurse, figure out the dose rate, communicate with the physician, see if they can give any verbal written orders to titrate this to a certain range. So we could do 0.02 mics per kg per minute, okay? Volume to be infused, we could just say we have, 250 mLs, okay? And then okay. And then next. All right, and then all you have to do is hit start. Now, with our IV pumps, of course, we already have norepi programmed in there. So I'm going to hit find. Actually, let me go back. This is a drug name list. I can hit MN, give it a second, it'll blank over, MNO, and I could probably find it that way. Search norepinephrine, 4 milligrams in 250, patient's weight, 70 kilos, okay. Now the good thing about using the using the pre-programmed norepi instead of just manually entering your own concentration is if I put my mics per kg per minute above what is recommended, it's going to let me know. So I'm pretty sure 0.5 mics per kg per minute is above, and it's going to tell me it's above the recommended limit of 0.4 mics per kg per minute. Press OK to proceed or back to change the value. So this is a safety feature for a reason. Another safety feature built in to these pumps, or another, I won't say safety feature, but a feature that allows you to manage this patient is the ability to provide a bolus. So let's say we're given an infusion of Versed. We have double checked this concentration. I'm going to hit start. So it's administering the medication now. It's going to go really slowly. But let's say we have just switched over and it took us some time to get the medication switched over. We didn't do a hot swap. Maybe we just added an extension set, primed the IV pump, primed the line, did all of that. And by the time we started moving the patient, they started waking up. Well, you can see that this is going in really slowly, and 5 milligrams over an hour is not a lot, especially in a patient that's being stimulated, being moved from the hospital stretcher to our stretcher. What we can do is hit bolus. I think the max that you can bolus should be 5, and we would bolus this just like we would any other patient. If we were giving Versed for post-intubation sedation if we didn't have a pump. So let's say that the math worked out to 5 milligrams. Okay, press OK, and then the pump is going to bolus that for us. What we don't want is our patient waking up midway outside of the hospital and then pulling their endotracheal tube and extubating themselves. Then we're in a whole lot of trouble. Now this also applies if you're transporting a patient direct admit to a facility and you have to walk down a very long hallway. It is you and that patient alone for minutes, could be an extended amount of time. So you need to make sure that you are comfortable bolusing these medications. So you need to make sure that you have everything that you would need to manage this patient under almost nearly any circumstance. Just because it's an interfacility transfer does not negate your responsibilities to provide the best care even in the hallway of the hospital before the patient gets to their room. What does this mean? Well, this means, one, knowing the pump, knowing how to titrate, knowing how to give a bolus. It also means that we take in whatever equipment we anticipate that we might need. This includes additional
sedatives, additional analgesics, and it also includes airway equipment. You don't want to be stuck in an elevator with a patient that wakes up, extubates themselves, and then vomits, and you have no way of clearing out their airway or ventilating them. That would be a bad day that you don't want to have. I want to give you some quick tips and tricks that you can use when determining what medications are compatible or not compatible. This can get very confusing, especially if you don't have a compatibility chart. I would recommend, if you're doing an interfacility transfer, to talk to the send-in nurse. They generally have a good concept of what medications are or are not compatible. A good rule of thumb, and I consulted Dr. Regan Baum, one of our good PharmD friends that really helps us out with some complicated issues like this, and she gave us some good tips that I can relay to you. She says that alteplase and pantoprazole are generally not compatible with any other medications. So vasopressors are generally compatible. Vasopressors are generally compatible with all other ACLS drugs, and I would say barring sodium bicarbonate, which can cause a precipitate in many of them. Antibiotics in general should be run by themselves and not co-administered with any other medications. And this is one of the main reasons is that if a patient has an allergic reaction, you don't know what you would not know what was causing that. But of note, ceftriaxone and cefepime can generally be given IV push, so you won't need a line for those. When it comes to sedation, you don't want to administer Versed or midazolam with propofol, but that's generally not an issue because you should not be administering those together in most cases anyway. So I hope that you all found that useful, and as always, if you ever have any questions, feel free to let me know. Thanks for watching.